So hi and welcome to the first episode of Core Cardiology Review series. For the introduction, Core Cardiology Review is an online lecture series that is designed to provide refresher and updates on various core cardiology topics organized by Asia Pacific Society of Cardiology. The materials provided by APSC through these webinars are in line with the aim of the ASC in preparing prospective candidates sitting for the annual European exams in core cardiology. Both of us will chair today's session. My name is Wishnu Aditya from Jakarta Heart Center, Indonesia, and joining me is Satoshi Honda from National Cerebral and Cardiovascular Center, Japan. Please, Satoshi.
So in today's episode, we'll be driving on acute cardiovascular care, featuring two lectures that will be delivered by our speakers, Dr. Ruth Chen from Woodlands Health Campus, Singapore, and Dr. Jayakhanthan Kolantha from Institut, Jantung, Negara, Malaysia. The first lecture will cover the management of shock and acute heart failure, while the second will give us an overview of thromboembolic and peripheral vascular disease. So we will also look at some provoking questions related to today's topic and discuss a bit based on those.
So some disclaimer and housekeeping here. The content of this webinar is copyrighted by the APSC. The view and opinions expressed are those of the faculty members and not necessarily represent those of the APSC. This webinar is live streamed via APSC Facebook and YouTube pages, and you will receive your certificate of attendance upon completion of a survey and will be sent via email post the webinar. So without further ado, let's get started.
So we'd like to welcome our first speaker, Dr. Ruth Chen, please.
Thank you, Dr. Wishnu and Dr. Satoshi. Let me share my screen now.
Yes, please, Ruth.
Okay, yeah. So once again, a big thank you to the course co-directors for inviting me and having me today to talk about acute heart failure and cardiogenic shock, which I'm sure it's something that we encounter quite often, and it's of course very close to our hearts. It's very close to my heart also. So first of all, I have no disclosures. So I think, like anything, we must start by defining what is acute heart failure and shock first. So we know that heart failure, it's when when the heart is unable to meet the body's demands or can only do so at the cost of increased filling pressures. Whereas for shock, it is actually a clinical syndrome where there is impaired end organ perfusion. So I think, therefore, we should always think about heart failure as a circuit problem, because this is when it is a clinical syndrome, or acute heart failure and shock is a clinical syndrome where the heart cannot deliver the adequate oxygen to meet the body's demands. So when we talk about heart failure and cardiogenic shock, we are not just addressing the ventricular failure, but I think we should address everything that's part of the circuit and think of it as a form of circulatory failure. So how do we approach heart failure? I think first of all, it's important to risk stratify our patients. We need to risk stratify them into whether they are high risk or non-high risk, and we can do so by some clinical and biochemical markers. I think next is to think about where we should monitor and where we should admit our patients to, and we should approach this in a very systematic approach. The approach I use is a top to a head to toe or top-down approach, where I start from A, I go all the way down to E. I think about the nursing and medical needs of the patient and admit them to the appropriate unit. And finally, we talk about the goals of care of any patient with acute heart failure. We want to correct the cause, we want to protect the heart, we want to support the hemodynamics, and also we want to decongest the patient. So first of all, we start off by risk stratification. After we suspect heart failure, the next thing we should really do is then to assess the patient in the whole clinical picture. So what I do is I do the same ABC approach. I assess the patient's airway and breathing. I assess the patient's respiratory rate, look at whether the patient is saturating well. At this point, it's useful to do an arterial blood gas. Next, we go into circulation. We will have the patient's blood pressure, pulse pressure, have a few of the pulses, whether the pulses are equal in both arms, whether the patient feels cold and clammy. I feel that even a quick capillary refill time is very useful as well. In D actually in my algorithm stands for delirium, but what we are really assessing is the patient's neurological and cerebral status. So in acute heart failure, cerebral hypoperfusion can manifest not just with any drop in GCS, but even a slight confusional state or being slightly lightheaded can be a manifestation of hypoperfusion. Next, E in my algorithm stands for electrolytes. So I look at the patient's urine output, I look at the kidney markers, liver markers, and most importantly, we also do a blood lactate at this time. And with all this assessment, we can now divide our patients into a high risk versus non-high risk group. By all means, non-high risk does not equals to low risk, but we categorize them based on high versus non-high. And by high risk group, these are the patients who have abnormal respiratory effort. They can either be very tachypnic, or if the patients are tiring out, then they can actually appear very lethargic with very poor air entry. Blood pressure that's low, obviously, is going to be high risk. Any lactate that is more than the upper limit of normal, which is 2, is considered high risk. And all this can manifest very quickly in the arterial blood gas that comes back quite quickly with base excess or metabolic acidosis. And of course, the signs of end organ hypoperfusion would mean that the patient is high risk acute heart failure. So not all patients with hypoperfusion will have low blood pressure. And blood pressure really is quite relative to what the patient's baseline blood pressure is. So a lactate is actually recommended in all acute heart failure patients as long as the blood pressure, systolic blood pressure, is less than 120. I think this table is familiar to most. This is the table that classifies our patients into who is warm versus cold, who are patients that are dry versus wet. The warm ones are the ones who are well perfused, and generally these are the sort of less high risk group, and they can be classified into whether they are normotensive or hypertensive. The ones that we are much more worried about are the hypoperfused, the cold ones. And once again, the lack of a low blood pressure does not mean that the patient is well perfused. These patients can still be underperfused, and we have to go clinically by looking at their pulse pressure, by feeling whether they are cold and clammy, and all the signs of end organ hypoperfusion. So let's talk about the slightly easier group, which is the non-high risk acute heart failure group. So in this group, they are mostly the warm patients, but they are wet. They come into us either with the blood pressure really high or the blood pressure being in the normal range. And this is really because of the underlying pathophysiology that triggered them or caused them to go into decompensation. So generally, these are considered the vascular type and the cardiac type. So the vascular type are the ones that come in with really super high blood pressure that suddenly comes on, and this is because of a fluid redistribution, and they go into heart failure because of fluid redistribution. So to tackle this underlying pathophysiology, first off, we don't give them diuretics first. We actually start them off with vasodilation, and then maybe give a bit of diuretics or low dose diuretics to offload them. So when we use things like furosemide, the main mechanism that we are actually employing when we use furosemide is really the vasodilation properties in this group of patients. And it also works very well if we start these patients on IV glycerol trinitrate or GTN. In this group of patients who are acutely breathless, positive pressure ventilation is also very useful because of the afterload reduction properties of positive pressure ventilation. And these patients with all these measures generally turn around quite quickly. The next group that we look at that is not the vascular type but the cardiac type of patients would be because they go into fluid overload because of fluid retention. And generally, this group of patients, their blood pressures can be normal, but how normal it is. So if generally, based on our books here, if the blood pressure is between 100 to 140, we can still use a bit of vasodilation. We start to use a little bit of diuretics at the same time. But if the diuretics do not work very well, we may need to think of mechanical measures like ultrafiltration in order to offload them and decongest them. In a group that, while the blood pressure is still sort of normal, it's still more than 90, but they are, between the 90 to 100 range, this is a group that we have to be very careful. If we give any vasodilation or diuretics in this group, we have to start them at a very low dose first, and we may even need a touch of inotropes in order to get their perfusion better in order for the diuretics to work. And really, this is the group of patients who are in the pre-shock stage, and we have to admit them into the right setting and monitor them very closely. So when I talk about that pre-shock stage, we are really looking at the stages classified by SCAI, or the Society of Cardiovascular Angiography and Intervention. So this is the pyramid of cardiogenic shock stages, and all our patients with heart failure are already at risk. So they are all stage A. But we are looking at the patients who are in stage B, and we have to be very careful with this group of patients. If they are in C, D, E, they are very obvious. We attend to them immediately. But it is the group B of patients that we need to pay a lot of attention to as well, because this is a group of patients who are in the pre-shock or beginning of cardiogenic shock stage. They may not have manifest of overt hypotension, but they may have some relative hypotension. Their blood pressure may already be 30, more than 30, less than the baseline blood pressure that they already have, or they may already start to turn tachycardic. And this is the group that we need to, put them in the right setting and monitor them very closely. So once again, we have to pay attention to which risk stratified group they are in, and then have a systematic approach where we assess every organ system, and then also take into account what sort of nursing and medical and clinical manpower we have. So for example, in the patients who are in that borderline blood pressure pre-shock group, if we see that they may need to go on some low dose inotropic support, then this is the group that we may want to consider continuous ECG monitoring, and maybe admit them, say, into the high dependency ward, or a ward where we can have higher level of monitoring. So next we go on to talk about, how do we manage our patients with acute heart failure and shock. So these are really the overview of the goals of acute cardiovascular care. And the first thing that I advocate is, number one, is to correct, and we talk about correcting the precipitant and the triggering factors. And there's this acronym given in the EECC syllabus that is called CHAMP. Next is we have to protect the heart, and we have to protect the vital organs. And this really boils down to good quality ICU care where we address every single organ, every single vital organ. Next is support, and support is about supporting the hemodynamics. The key here is to maintain and improve end organ perfusion. We want to improve the stroke volume by addressing the preload contractility and afterload, failing which we need to think about mechanical circulatory support. And of course, because our patients are in acute heart failure, if they are wet, we must decongest them. And decongestion really is a chicken and egg between preload and perfusion. Sometimes we actually need to decongest our patients in order to improve forward flow and improve perfusion. So it is a circle of continuous assessment between supporting our patient and decongesting them. So correcting the underlying cause, in the EECC guidelines, these are the CHAMP causes that we must initiate treatment within the first 1 to 2 hours upon first medical contact. So CHAMP, C for acute coronary syndrome, H for hypertension, A for any arrhythmias. This can be your atrial fibrillations with rapid ventricular rates. Always think about whether there's any underlying acute mechanical cause where we need to refer to our surgical colleagues immediately. And don't forget, not just the heart, but the rest of the circulation. So pulmonary embolism as well, which Dr. Jaya will talk to us about later. So I think our patients can have more than one pathology, and therefore we must always treat the patient and not just the disease. That means even if we find that there is one obvious cause of pathology, we must always think about whether there are any other causes of shock and whether there are any other triggers. So look at the blood pressure, look at the pulse, feel the pulse on the other side, whether there's any differential pulses. We will definitely do a 12-lead ECG. Point of care ultrasound nowadays is almost quite commonplace if we have it. It's very useful to pick it up and do a quick echo for our patients. We just need 4 to 5 views. So let's see, that's this play. Okay. So just very quickly, you can see that this is actually a acute aortic dissection. This one obviously is tamponade features. This patient, very quickly we can see that there is actually acute mechanical cause causing MR. And I think now we have run into a bandwidth issue.
That's okay, Ruth. Probably you want to continue first.
Let me do a hard restart on this.
Okay. Too bad.
Yeah. Thanks to ambitious with the videos in this.
That's okay. We already heard lots of interesting things from you. So the main thing is, although the condition in acute and for the acute cardiovascular care is very various, it's actually interesting that all the society tries to make it more structural. So you have some goals of the acute cardiovascular care, like you said, correct, protect, support, decongest. But in real world, do you really use those structures?
I do.
Yeah. Do you always keep those things in mind?
I do. So I think in our books, especially our cardiology textbooks, we focus a lot on C first. We go to circulation. We start by correcting the blood pressure, starting vasopressors, inotropes. But I think having a framework that says first we have to really take note what is the precipitating factor, identify the triggers, at the same time quickly institute proper ICU care, and then go down to a framework of maintaining perfusion through the use of vasopressors, and then always addressing all the different components that improve stroke volume, so preload, afterload, contractility. So this is the framework that as an ICU physician is what I use, and I think it marries very well with what we do in cardiology as well. All right, so just let me go back to the slide. Yeah.
Okay.
And perhaps try to skip the one of the videos. But the point about showing the point of care ultrasound is that a very simple 4 to 5 views, or even just that typical 4-chamber views, we can really tease out that our patient can have more than one pathology when they come in with acute heart failure. So a patient with a dilated right heart, can they also have a pulmonary embolism? When a patient has a STEMI, can they also have acute dissection and tamponade? I think all these are possible, and that is the main thing we should think about, whenever we want to correct the precipitating factor.
Yeah, we can discuss a lot more about focus. It's very interesting.
Yes.
Yeah.
Okay.
Dr. Ruth, thank you very much for
Am I back online? Are the slides back online?
Do you have something you want to deliver, Satoshi? You want to ask or deliver?
So, yes. Please start.
Okay.
Okay, maybe yes, we can talk about progress, but yes, so as mentioned, just a quick paracenter long axis subcluster 4-chamber views, we can get an overview of what's really causing the problem. And as cardiologists, there can be many causes. We think not just the ventricle, but we think about the feeling, the contractility, and actually even the pericardial can be a source of problems, whether it causes effusion and tamponade, or it can cause pericarditis and constrictive pericarditis. So this okay. So going on to treating the precipitating cause. I think about it as, the preload, the afterload, the contractility, the pump problem, and whether it's also a filling problem. So in terms of preload, not just the acute CHEM causes that we have to treat within the first 1 to 2 hours, but we also have to think about what is the trigger. So is it because the patient has an underlying infection, the patient has fever, a patient didn't take his medications, or for the reason that he was sick, he couldn't absorb the medications well, and therefore cause decompensation. If you think about afterload issues, we will have things like our hypertensive crisis and acute PE. Contractility issues are the ones that we are most familiar with, but there are other causes that can cause impaired myocardial contraction. So in severe metabolic acidosis, certain drug overdoses can also cause impaired contractility, and not just a ventricular pump, but then the relaxation is also a problem when the patients are too tachycardic, or if they have any pericardial disease. So the next step, when we are thinking about correcting the precipitating cause or the triggering factor, what we also need to do at the same time is to protect the heart and protect the rest of the body. And this is really about providing good quality ICU care in our CICU. So I use a head-to-toe approach as well. So in our patients in ICU every day, we address their airway and breathing. If we think about whether our patients need to be urgently intubated, if not, starting them on non-invasive positive pressure ventilation, what are our ventilatory settings? Are we protecting the lungs? Are we using lung protective ventilation settings? What are our oxygen and carbon dioxide targets? Circulation-wise are what we are familiar with. We want to optimize hemodynamics and maintain end organ perfusion. D is really about addressing the patient's neurology, ensuring that our patients are regularly reoriented, because the ICU environment, the CICU environment can be very confusing. And when I think about neurology and delirium, this is where I also address symptoms like dyspnea, symptoms like pain. A lot of times, opioids, morphine, fentanyl may not be the first line anymore in treating our patients with acute heart failure. But certainly, if our patients are experiencing any distressing symptoms, we may need to use a little bit of analgesia or even opioids to address that. EFG stands for electrolyte fluid, gut, and glucose. So while we are diuresing our patients, we also need to think about other aspects of electrolyte maintenance, gut protection using proton pump inhibitors, our choice of ICU feeding. In this group of patients is very important as well. If our patients are in respiratory distress, they may be kept nil by mouth, but we cannot keep them nil by mouth for too long. If they're intubated, we start them on enteral feeding through a nasogastric tube. Then it boils down to what is the choice of feeds. Maybe we want to choose some feeds that are high caloric but low in volume and low in sodium. And of course, our patients with cardiovascular risk factors, we want to keep them in a very tight and normal glycemic range. Hematology-wise, it's important to correct all the aspects where oxygen delivery can get affected, because heart failure and shock is really a problem about circulatory demand and supply. So anemia is something to be addressed. DVT prophylaxis is important in suitable patients if their bleeding risks are acceptable. And of course, our patients in the hospital itself can be very prone to infections. So simple and straightforward ICU care would be things like keeping the head of bed up 30 degrees to reduce the risk of pneumonia, removing any unnecessary IV plugs or catheters, and of course, if our patients are antibiotics in the broad spectrum ones, we might want to stop or de-escalate them when it's clear that they don't have an infection or they have recovered already. So protect is really about the rest of the organs that is apart from the heart that we are concentrating on, and providing good quality ICU care in our cardiac ICU. So some of the things that I also wanted to talk about in acute cardiovascular care is the ventilation strategies that we use. And we always talk about lung protective ventilation, but really the positive pressure ventilation that we give are also heart protective as well. And what a lot about this is the targets that we set and the ventilation settings that we set. So what our oxygen targets, really is about a Goldilocks kind of scenario. We don't want too high and we don't want too low. We know that obviously hypoxia is not good, but oxygen administration should not be routine, and we need to avoid hyperoxygenation as well. The generation of free oxygen radicals can in turn cause vasoconstriction of microvasculature and can actually cause myocardial microcirculation constriction, as well as carotid and cerebral vasoconstriction. So this will actually impair our perfusion of these organs. Straightforward lung protective ventilation, like all things, we want to keep the plateau pressures in the lower range, less than 27 to 30, driving pressures less than 15. We also want to avoid pulmonary vasoconstriction, especially in right heart failure, because of the increase in pulmonary afterload. So what we can do is to maintain tidal volumes of usually about 6 to 8 mL per kg, and avoiding giving too little or too much lung volumes, because at these extreme ends of tidal volume delivery, we actually exert pressure or opposing forces on the capillaries within and outside the lung alveoli, and thereby actually increasing pulmonary vascular resistance. So 6 to 8 mL per kg is usually the ballpark of optimal tidal volume. So I tend to get this question quite frequently, so I thought I will include it in this slides about, in certain cases, why is it that when we start our patients on positive pressure ventilation, why is it that sometimes the blood pressure drops, and yet it's something that we actually advocate usage in acute heart failure, and this actually really boils down to how does positive pressure ventilation affect our cardiac and circulatory system, and it boils down to whether patient is currently at that stage of starting positive pressure ventilation, whether the patient is in a preload predominant physiology or an afterload predominant physiology. So what does positive pressure ventilation do? So positive pressure ventilation is when the intrathoracic pressure is increased. So it causes a decrease in RV preload, increase in RV afterload, decrease in LV afterload, and an increase in LV preload. And the summation of these four effects on the left and right heart, and the net overall effect on the stroke volume really depends on what is the predominant physiology at the time. So a preload dependent physiology would be a patient who is, say, septic shock and hypovolemic, and therefore when you start the patient on positive pressure ventilation, the blood pressure drops because the stroke volume drops. But in our patients with heart failure, a lot of them actually have LV dysfunction, and LV dysfunction is actually a predominant afterload dependent physiology. So when we apply positive pressure ventilation, we actually increase the intrathoracic pressure, we decrease the intramural pressure, and by then we decrease the LV afterload. And this is actually the predominant effect that we see from positive pressure ventilation, and the net effect of this decrease in LV afterload improves the stroke volume. Now, of course, the additional benefit of positive pressure ventilation in our heart failure patients is that it decreases then the RV preload, and by that effect, it actually decreases the overall preload for our patients who are already overloaded. So that is a quick summary on the use of ventilation. Going on, we talk about optimizing hemodynamics, and this is really about supporting the patient. We want to support the patient's perfusion as our main goals. We want to make sure that the end organs are well perfused, and when the blood pressure is low, when the patients are not well perfused, the first thing we need to start are vasopressors. Then we address the stroke volume through the three arms: the preload, the contractility, and afterload. And these are some of the targets that we can look at in preload, contractility, and afterload. So in a patient with left heart failure, generally we want to aim for a wedge pressure of less than 18. In a patient with right heart failure, we actually want to keep them not too dry but not too wet, because if our right heart failure patients are too wet, that RV distension will then impede LV function. Contractility-wise, in general, we are aiming for values more than 2.2 to 2.5. And of course, in afterload, some of the medications that we give will be vasodilation, and whether we target the pulmonary or the systemic circulation depends on whether the patient is in right or left heart failure. Of course, considering all of this, we will think about all the percutaneous mechanical circulatory supports. So what I want to highlight here is that this is a chart taken from the ESC and the EECC textbook, showing that cardiogenic shock has many underlying mechanisms that cause it. And there is also an element of systemic inflammatory response and the generation of pro-inflammatory cytokines when the patient is in heart failure and shock. So what it really means that, heart failure is also an inflammatory state, and therefore this inflammatory state can also cause a little bit of vasodilation on top of the cardiogenic shock components. And therefore, anything that affects the supply and demand can also exacerbate heart failure and shock. And what I mean by reduction of supply, so if our patient is hypoxemic, anemic, when there's insufficient stroke volume, when there's this vasodilation component due to the inflammatory response that can happen in heart failure, this reduction in supply exacerbates shock states. And it's also important to remember that anything that increases or worsens demand can also make shock worse. So if our patients are very tachypneic, they have increased work of breathing, we might want to think about escalating them from not just NIV to intubation, because that actually decreases the work of breathing. And by decreasing the work of breathing, we are decreasing demand. And by decreasing demand, we can actually improve the perfusion to other places or other organs that needs that supply more. So we have to address agitation, fever, or anything that worsens demand. Perfusion wise, we so the most commonly advocated vasopressor that we use first line will be noradrenaline. We are actually employing the alpha 1 effect when we use noradrenaline, and at low doses we are talking about doses of generally less than 1 microkg per minute. The main use is vasoconstriction, especially at the end organ level, to improve systemic perfusion, and there is also a small inotropic effect. At doses that is beyond that 1 microkg per minute, it actually causes more adverse effects already, such as raised pulmonary artery pressures and pulmonary vascular resistance. So the two main trials that have compared the different vasopressors would be the SOAP2 trial. So the SOAP2 trial really looks at dopamine and NORAD, and has really changed how we practice and how we treat shock, including cardiogenic shock. So even though this SOAP2 trial looks into all comers shock groups, there is a subgroup of cardiogenic shock in patients in this trial that showed that the dopamine group actually had more deaths, and therefore we should really look towards using noradrenaline as the first line. So because dopamine itself is more arrhythmogenic, and also because the higher heart rates, the higher tachycardic rates that's caused by dopamine is postulated to actually cause more ischemia. Then there's also another trial that looked at whether we should just use adrenaline. So this is the OptiMax study, or where they looked at epinephrine versus norepinephrine. And although the in terms of whether the cardiac index improves or not is the same in both groups, adrenaline itself actually also causes higher heart rates, and it also produces lactate through a type B mechanism, and actually showed that there was a higher incidence of refractory cardiogenic shock. So all in all, the key take-home message here is that our first-line vasopressors when the blood pressure is low is to use noradrenaline. Next is we are talking about decongestion, so that's about diuretics. Then we'll talk about sequential nephron blockade. Loop diuretics is our usual weapon of choice, and failing which we add on thiazides, which addresses the more distal part of the nephron system. Last year in ESC, they talked about the ADVOR group study, and this is where IV acetazolamide was added on top of loop diuretics for decongestion. And I think a lot of times our patients who are very sick gut edema as well, and therefore it's useful to have an arsenal of medications which can be given intravenously, and sometimes a combination use of medications that target different levels of nephron is useful. So more of less dose of two different groups is somewhat better than a lot of one group, and this is what it means. So if our diuretics itself do not work, we might need to think about ultrafiltration, and our diuretics may not work is because our kidneys may not be optimally perfused yet. And this is especially true in right heart failure patients where the right heart is very overloaded. They cannot pump the blood out because of its compression on the LV, and therefore we might actually need to ultrafiltrate and remove some fluid first in order to optimize the preload and optimize perfusion before the diuretics can take effect. Next, we talk about contractility, and the ideal inotropic or contractility agent is really one that increases inotrope support, have very minimal arrhythmogenicity effect, and one that we can titrate easily at the bedside. And for right heart failure, we want one that actually dilates or doesn't vasoconstrict the pulmonary vasculature as much as it does on the systemic vasculature. So this is a table showing the three common inotropic agents that we use. We have the sympathomimetic agent, which is dobutamine, and then we have our Mirinone and levosimendan, all of which works in a slightly different way. Now, the doses that I display here, the first row actually shows the doses that I frequently use, or what we frequently use in Singapore here. So we start off low. In a lot of our patients, if the doses are too high, they can actually cause hypotension, they can actually cause tachycardia, and this is not what we want. We rather start them at a low dose. So for dobutamine, we may want to start there at 2 to 3 mics per kg per minute. And Mirinone and levosimendan, we generally avoid a bolus dosing if our patients are already hypotensive. We might actually need to start the patient on noradrenaline first before we add some of these agents. So the good thing about dobutamine is that it's very easily titratable. It is useful in patients with acute AMI, and we want to have a quick titration of the medication because dobutamine has a very short half-life. Mirinone and levosimendan, the half-life is a little bit longer. Levosimendan has a half-life that's very long because of its active metabolites. Both of them have good contractility effects. And what is even better about levosimendan is that it also has some molecular benefits by improving the diastology and of the underlying musculature because it's a calcium sensitizer. So it actually causes less myocardial oxygen consumption and has actually improved the renal perfusion and the glomerular filtration rate better than dobutamine. The next thing is Mirinone and levosimendan is also useful for patients who are already on chronic beta blockers, whereby dobutamine will not be so effective in. High doses of Mirinone and levosimendan generally can also cause tachycardia, can cause ectopic bleeds, can cause arrhythmia, can cause atrial fibrillation, and of course, because they are vasodilators as well, they can cause hypotension. Afterload wise, when I think about treating the patient's afterload, if the patient's blood pressure is high, or the blood pressure can tolerate a bit of vasodilation, some of the medications that we can use would be nitrates with a combination of hydralazine. Sodium nitroprusside is less commonly used nowadays because of its effect on both the arterial and venous tone, so it can really cause quite remarkable hypotension. So it's more used in the group that are non-high risk vascular type of acute heart failure.
So
and
I think
there's
another 5 minutes, Ruth. We
all
are
right.
behind.
Yeah, I have 5 slides. Okay. And afterload reduction can also be done through the use of an IABP when it relaxes in systole. And we talk about pulmonary vasodilation if we are looking at right heart failure, and we should really use inhaled pulmonary vasodilators as opposed to systemic ones because we want to deliver the vasodilation directly to the pulmonary vasculature. And so going on to my last few slides, failing all of this medical and ICU non-invasive therapy, then we are looking at mechanical circulatory support already. And these are the classes between the right and left. So we have our IBP, impeller, tandem heart, as well as the new pulse cath IVEC 2L. And the main thing to highlight here is the different levels of flow of cardiac output that they can support. Of course, IBP being about 0.5 to 1 liters, IVEC 2L being about 1.5 to 2. Impeller nowadays we can go to 5 liters. And not all MCS devices are made equally. So apart from the flow that they can deliver is different, we have to also bear in mind that there are certain devices like ECMO itself can actually increase the patient's LV afterload, which is not what we want. And the myocardial oxygen demand of some of these devices can also be very high, such as ECMO and tandem hearts. The ones that actually reduce the afterload and reduce the oxygen demands are the ones that causes this LV unloading. So IBP as well as impeller and IVEC 2L can help with it. But the take-home message really is that if our patients are in that refractory stage, or at the stage C, progressing to stage D, we really need to involve our colleagues in intervention, heart failure, as well as our surgeons. And there are certain, we think about, what is the trajectory of cause or clinical cause that the patient is going to have. Can we treat the cause and treat the triggers quickly in the next 24 to 48 hours? What are the patient's comorbids? If not, do we need to escalate our care to MCS devices early? So really what we want to achieve at the end of all this is that we want to improve perfusion, we want to improve the patient clinically, and we want to see an improvement in all the other markers as well. And of course, we should also not neglect the other non-cardiovascular comorbidities. So in summary, very quickly, we are looking at form of circulatory failure, and our aim is to restore perfusion. We want to risk stratify our patients. We also want to admit our patients into the correct setting, and we want to correct the cause. We want to protect the heart and protect the other organs by having good ICU care. We talk about supporting our patients' hemodynamics and improving perfusion, noradrenaline being the first choice of vasopressors. And we also want to decongest our patients and optimize the preload, contractility, and afterload, and consider the use of MCS if needed. So I'm happy to take any questions either through here or through email. Thank you very much.
Thank you very much, Ruth. That was a very nice, comprehensive lectures, and I'm sure you don't have enough time to explain everything, and looking forward for another lecture from you in the future.
Yeah.
For sure. Do you have any provoking questions that we can look at, or we can just discuss?
I think there's a question on the chat asking,
Okay.
how do you measure the cardiac index by echo invasive? I know Ruth is typing the answer right now.
Yeah. Do you want to just answer that live, Ruth? How do you usually measure the cardiac index in your sensor? I think Ruth is.
Oh, I think she's. Yeah, I think she's.
Yeah. Do you want to talk about that, Satoshi, being a cardiac intensivist yourself?
Yes.
Usually measure cardiac index.
Dr. Alice is probably now online.
Oh, so you measure it by echo usually, or?
Basically, I use echocardiography for the assessment of acute heart failure, including cardiac index. But in some high-risk patients, we place pulmonary artery catheter for the simultaneous monitoring and the assessment after the treatment. So it depends on the patient status. Dr. Luce, do you have any opinion about that?
So I think both ways, whether is it by echo or whether is it through more invasive measures, are fine. No, I think echo gives a quick estimate, but it is also very operator dependent, because when we want to actually measure the cardiac index, we need to have a consistent LBOT tracing, and it may not be very easy to get, depending on our patient's position, and if the patient is very tachycardic or tachypneic, they are sitting up, and we can't even do the echo well at all. I think the key in patients who are very sick in the ICU is to have a form of continuous cardiac index monitoring, and not just static, taking snapshots of the patient's cardiac status. So generally, I would then use something that is either a little bit more minimally invasive to the more invasive ones. So if I am worried about, the patient is not on vasopressors yet, then I may use a pulse contour monitoring to look at the cardiac output. If the pulse contour is reliable, the patient is not atrial fibrillation or have a lot of ectopics. But if the patients are in shock already, then yes, to answer Idato's question, that yes, I would use a pulmonary artery catheter, because I think that gives me a lot more information. I think our early studies, showed that PA catheter really has no mortality benefit in cardiogenic shock. But I think now that we have a better understanding of different hemodynamics and how to address all these components of the hemodynamics, the values that the PA catheter provide are useful, and the modern day PA catheter can also measure all these values continuously, and not just a static thermal dilution. So we have Swan-Ganz catheters that have a thermistor in them that heats up the blood and then actually measures the cardiac output continuously. They can also give us the values of the RA pressure and the wedge pressure, and how do we achieve those targets. We can do them more precisely. So we can start off with echo, but if our patients are very sick, then yes, I would actually advocate the use of more invasive measures.
Okay, great. Since we got lots of questions, probably we can just continue with the next question in Q&A. So it's about the recommended hemoglobin that we should aim for. Any comment, Ruth, for patients with shock?
So for most most ICU patients, if there is no ischemic precipitant, then generally a value of more than 7 is okay. But I think a lot of our patients, they have an ischemic component. So especially if they have ACS, then I would actually use back the conventional targets of more than 8. And this is what the British guidelines actually advocates. I don't know about in other centers. What do you all do? Do you all aim more than 8, more than 9, or sometimes yeah.
For us, if we have coronaries, if coronaries are involved, we'll keep it above 10 usually. Yeah.
What in your center, Satoshi?
Yes, it's very difficult question. Although the evidence does not support the exact hemoglobin level in patients with acute heart failure, we usually consider 10 milligram as the optimal cutoff for the lower hemoglobin level, especially in ischemic heart disease patients.
Yeah, that will be the common sense. And the next question is also really good. And how about with the patient with end-stage renal failure and with hemodialysis? How will your hemoglobin target be? Do you have any specific comment on this? Ruth, probably.
I mean, personally, for myself, it's not any different from the other patients that have that do not have end-stage renal failure. I think, of course, they'll bear in mind what their baseline hemoglobin is as well. So, for example, if their baseline is 14, then of course a 7 to 8 target may be too low. That's half the amount. So, of course, I want to target something that is more than 9 to 10. But if they start off coming in with a HB of say 7 or 8 in the ESRF, then keeping it around 7 or 8 is fine.
Yeah, they tend to tolerate lower levels of HB anyways.
Yeah, we got reconditioning. So probably we will answer the last question. So this is also a very interesting question but from Bon Chung Be about will you consider tolvaptan upfront? And also I have a personal question. How to bridge between your care and from the usually heart failure team, because they will really keen to give GDMT really early, and while you're managing the acute heart failure situation. Do you have any comment on this, Ruth?
So the first question about, generally I will not use tolvaptan up front. I think the main thing in our patients with acute or pre-shock stage is I generally go for a medication that have reliable absorption, and therefore I think tolvaptan, number one is it doesn't have an intravenous form of administration. The other thing is that the sodium levels as well as the liver markers also need to be closely monitored in patients on tolvaptan, and therefore in patients who are in that hypoperfuse or peri-hypoperfuse state, the sodium and transaminitis and even the kidney markers can be quite unpredictable. So generally I would still consider a loop diuretic first, and actually I have used IV acetazolamide. What I use is a bit lower than what is used in the ADVOR trial, so I use about 250 as and when. I don't give it every day, but as and then to see the effect on diuresis. And then how do I bridge the care going from the acute to chronic? I think in our patients who are in shock, a lot of the medications will actually cause a drop in blood pressure, can also worsen renal function. Even SGLT2s will not be ideal. So generally, I don't use any of this. But once our patient has start to go into a more stabilization stage where they can go up to the ward, go to the general ward soon, then what I want to see my patients at least tolerate would be a afterload reduction agent. So I might want to start my patients back on a low dose of ACE inhibitors or ARB first, and this is usually the first choice that I use. Unless of course the patient is very tachycardic, then I would of course choose to start a bit of beta blockers. I think the key is that once I know my patient's trajectory is going to get better, then this is where I also want to quickly restart them on GDMT. I would choose the lowest of all rather than the highest of one, and start as many components as I can, but at low doses.
That's great. So thanks Ruth. It's been a great discussion. So we have to jump to our next speaker. So next, Jaya will present about overview of thromboembolic and peripheral vascular disease. So please, Jaya.
Sure. Wait. Give me a second. Yeah. Somehow.
And I'm sure Ruth will also help us in answering those offline questions that we cannot answer everything live.
No problem.
Okay, thank you everyone, and thank you for inviting me to share about thromboembolic and peripheral vascular disease. So I'm Jaya from IJN in Malaysia. So I'll basically talk about three things: acute limb ischemia, DVT, and pulmonary embolism, and my talk is basically based on the EECC guidelines. So when we talk about peripheral vascular disease, we're talking about lower limbs, we're talking about lower extremity arterial disease. They usually present in three ways. Either they present with the intermittent claudication, pain when walking and goes away at rest, or they come with a critical limb ischemia, basically pain at rest, some tissue loss, or ulcers and gangrene. And the most debilitating of them all is the acute limb ischemia. So as the disease progresses, the symptoms get worse and the walking distance gets shorter. Yeah. Now, in acute limb ischemia, there's a sudden decrease in arterial perfusion of the limb, threatening the viability of the limb. So major cause of this is embolic diseases followed by thrombosis, usually associated with atherosclerosis. So and this is 30 times less common than chronic limb-threatening ischemia. But lately we're seeing more of acute or chronic limb ischemia, and with an ALI, 30-day mortality is very high, up to 10 to 15%. The major risk factors for ALI are AF, MIs, patient smokers, atherosclerotic disease, if they had previous limb revascularization or surgery, especially grafts. Now, when we look at clinical features, I think in ALI, they talk about the 6 Ps. Patient comes in early with pain, pallor, pulselessness, and perishing cold. When they can come in related with paresthesia and paralysis. Now, this is the Rutherford classification of acute limb ischemia, graded from 1 to 3, and mainly looking at sensory and motor deficit. And as it gets higher, obviously the prognosis gets poor. And in acute limb ischemia, the recommended investigation is a duplex ultrasound or a DSA, which are frequently used. But if the patients are in Rutherford 1 or 2A, a CT scan may be considered to guide treatment. However, imaging should not delay treatment. That is a very important point. So when we look at this algorithm, I think this is basically summarizes treatment of ALI. The key important thing is if we suspect an ALI, unfractionated heparin should be instituted immediately. Patient should be given adequate analgesia. Now, if the patient is in Rutherford 1, where there's viable no neurological deficit, we may take a few hours. We're not talking about days, we're talking about a few hours to do a duplex ultrasound, maybe a CTA, and then decide what form of revascularization we want to do, but it has to be done within hours. So mind you, the ALI means the symptoms have started within 14 days. And in our Asian cohort of patients, they don't really come very early. They tend to present much later. So you can decide which way you want to revascularize, either by thrombolysis, thrombectomy, or by bypass. So if they already have a neurological deficit, so they don't even warrant a workup. You just go do most of the time is an angiography, and then they decide whether they do a thrombectomy or a bypass. And if they are in Rutherford 3, most likely patient will lose the limb. So they're a bit too late. So after the initial revascularization, if you achieve flow, then you go back and look at what is the underlying cause. And if there's anything, then you decide whether you treat it endovascularly or with surgery, and then optimal medical therapy. Now, there was a large study, about 1,000 patients, in the Rochester-style TOPAZ study. Basically, they compared catheter-directed thrombolysis with open surgery, and there was not much different in 30-day mortality or limb salvage in those group of patients. So, the combination of intraarterial thrombolysis and catheter-based clot removal seems to be associated with 6 months amputation rates of less than 10%, which is very good. So when we talk about endovascular management, to be very honest, in the real world, even though we say surgery is better or whatnot, but a lot of these ALI patients are quite ill. They may not be surgical candidates. So catheter-directed therapy sometimes become very important. Now, in the last maybe 4 or 5 years, at least in Malaysia, where we've been using ECOS catheters, which is basically an ultrasound catheter with a direct thrombolysis, and this was studied in the DUET study, shows actually you can revascularize the limb almost 12 hours earlier, and you use much less thrombolysis, so lesser bleeding in that sense. Or you can use a percutaneous thrombus aspiration, like the Indigo Penumbra device, which is a manual aspiration with a large catheter. And you may also combine that with thrombolysis. Or you use mechanical thrombectomy. And this, the mechanical thrombectomy really works if the patient presents more than 14 days. And sometimes when they come in, the clots are not really soft anymore. So you need things like Rotarex or Angiojet to achieve flow. Just moving forward, in terms of prevention, I think these 2 studies, the COMPASS and Voyager studies, has given us a sort of, we're adding rivaroxaban 2.5 milligram BD. Actually, there is a great reduction in major adverse limb events. So this is sort of prevention if patient has atherosclerotic disease, even unstable, or they've already presented to acute limb ischemia. Adding on a rivaroxaban low dose seems to help. Now, I just want to address these 2 things. I mean, this is a very busy slide, but the focus is on claudicants. So when patients present in claudicants, the main advocate here is an exercise therapy, statin and Plavix. And if the lesions in the aorta or femoral popliteal are short, in the aorta less than 5 cm, in femoral popliteal less than 25 cm, then endovascular treatment is first. And if the femoral popliteal lesions are very long, more than 25 cm, bypass surgery with autologous saphenous vein is recommended. Now, in the chronic limb threatening ischemia group, where a lot of patients have actually infrapopliteal disease, again, the recommendation is actually for surgery with a great saphenous vein bypass, and endovascular therapy is like a sort of a class 2A. So that concludes ALI. So for me, recognition of ALI is the most important, and then immediate treatment. Maybe not all of us will have a vascular surgeon on board. So either the interventional radiologists or the interventional cardiologists have to do something. And as I mentioned earlier, in the real world, endovascular therapy may be preferred to surgery as patients are generally more ill. Now, coming on to the second part of things, DVT. DVT, just defining DVT, is a formation of a semi-solid coagulum within the flowing of the blood in any of the deep veins of the body, and then lower limb or the pelvic veins. And we know the pathology, we've learned this in medical school, the Wirchhoff's triad. I'm not going to go through that. So if we have a patient coming in DVT, I think the guidelines now are geared towards risk stratifying them in order to deliver appropriate treatment. So there are certain presentations. So a good history is very important. That presents with a higher odds ratio. So they have strong risk factors. They divide them into either moderate risk factors or weak risk factors. And for DVT, the recommendation is to use Wells score. Yeah, they have a 10 parameters here. I will not go through each one of them. They're easily accessible and in like sort of a online, what do you call calculator. Exactly, that's the word. Thanks. So the 2-level modified Wells score is recommended to stratify the patient to either unlikely or likely, right? So based on that Wells score, if DVT is unlikely, then they warrant to use D-dimers to further risk stratify them. So if D-dimers are positive, then only venous ultrasound is done. But if DVT is likely, then venous ultrasound is done to determine either proximal or isolated distal DVT, and later on to tailor treatment. Now, in terms of D-dimer, the latest sort of consensus is to use an age-adjusted cutoff levels, which says that there's an increase in D-dimer specificity. So basically, it's age times by 10. So if your D-dimer is higher than that, then the likelihood of you having DVT is likely. So, and D-dimers are only used in an unlikely scenario rather than a likely scenario. And venous ultrasound obviously is the first line imaging for DVT, and sometimes even in PE, if you suspect a PE, a confirmation of a DVT can clinch the diagnosis. Now, coming back to the treatment, I'm focusing on the proximal DVTs because this is the most common kind. It's recommended that we give at least 3 months of anticoagulation, and NOACs are the forefront in non-cancer patients. And the guidelines have added that we should add on compression stockings immediately within 24 hours and access indication for reperfusion if necessary. Following this, then on follow-up, we reassess the patient with venous ultrasound, look out for PTS, and then based on that, decide if anticoagulation should be stopped or should be extended. Now, treatments, of course, if there are no contraindications, NOACs are the first line preferred in non-cancer patients. Dabigatran and rivaroxaban needs overlap, but otherwise, the rest of the NOACs are all indicated. Now, just to touch on thrombolysis, thrombectomy, or CDT for for DVT, cancer-direct thrombolysis is not recommended routinely and reserved for individuals with very severe cases, and also recommended to perform only in experienced centers. So primary acute DVT stenting or thrombus removal are usually not recommended. But having said that, I mean, on a personal experience, patients who have been started on DVT treatment within 2 or 3 weeks with no resolution of the leg swelling, and I personally have had I would say unlucky need to intervene. It's a very cumbersome intervention, but with the new ECOS catheter, I've been getting some good results. So now moving forward now. IVC filter. The consensus is that we only should consider IVC filter if anticoagulation is absolutely contraindicated, or in the case of recurrent VTE, even under adequate therapeutic anticoagulation. Now, if we consider extended DVT management, we should individualize the approach. So extended means anything more than 3 months. So patients with recurrent VTE, patients have an active cancer, antiphospholipid syndrome, or for hereditary thrombophilia, a strong family history, or they have a first episode of non-identifiable risk, especially in men with a proximal DVT with or without PE, high D-dimer and increasing age. Of course, if the bleeding risk is low. So we may consider anticoagulation, and if in the intermediate risk, we may even consider to reduce NOAC. And of course, in antiphospholipid syndrome, warfarin is advocated. Now, during follow-up, we should check the patient's Vilata score for PTS. Yeah, if they have high compliance to elastic stockings, we should continue compression. If they have symptomatic severe post-thrombotic syndrome, we may consider reperfusion. I'm not sure if any of you guys had an opportunity of using a compression stocking. Let me tell you, it's not comfortable at all, and it's almost impossible to find a patient who would use it 6 to 7 days a week all day. Almost impossible unless they're admitted in the hospital, right? So now, for extended DVT treatment, basically the guidelines suggest that we use risk scores. There are a few risk scores: Vienna risk score, HER2, the DASH, or the DAMUS risk score. So based on this, we can decide whether we need to continue the anticoagulation or not. Patients in low risk, we stop at 3 months. Patients at intermediate risk, we can consider continuing if the bleeding risk is low, and we can reduce the dose in the intermediate risk if necessary. Patients in high risk, of course, we should continue if provided the bleeding risk is low and there are no contraindications. And as I mentioned earlier, antiphospholipid syndrome recommendation is for warfarin. Now, in cancer patients, the cancer patients have been sort of given a special update in 2021 for the management of DVT. So they prefer low molecular weight heparin over unfractionated heparin for initial treatment and long-term treatment. But we may consider doxaban, rivaroxaban for initial and long-term treatment. As an alternative in patients without GI or urothelial cancer. Apixaban may be considered for patients without primary or metastatic brain cancer or acute leukemia. However, if patients have very low platelet counts, have nausea and vomiting, and they have risks of drug interactions with the anti-cancer, then we go back to low molecular weight heparin. In pregnancy, again, ultrasound is recommended. We try very hard not to do a CT scan. Sorry, I think I'm mixing that up with pulmonary embolism. My apologies. So ultrasound is recommended as the first line. Yeah. In pregnancy, again, low molecular weight is initial and long term, and we should continue the treatment for at least 6 weeks after delivery, with a total of 3 months treatment. So for DVT, early recognition and treatment is important to prevent long-term sequelae. NOAC is preferred. Extended treatment is considered based on risk score assessment, like I mentioned earlier, and in cancer and pregnancy, low molecular weight heparin is preferred. Now, coming to pulmonary embolism, I'm sorry if I'm speeding a little bit because I'm just catching up for time. But of course, if there are any questions, please shoot it out. Now, pulmonary embolism obviously is most common preventable cause of death in hospitalized patients. There are almost 600,000 deaths worldwide. They account for 1/3 of symptomatic VTE patients, a very high recurrence rate. And during the pandemic, they were, associated with up to 25% of admissions of patients for COVID-19. Almost 1/5 die before diagnosis. Maybe that is getting lesser now because we are better at recognizing and treating it. And case fatality rate is about 12% in the first month. So again, the guidelines tell us that to recertify these patients, we take a good history, and then we go based on how bad their risk factors are. So whether they have high odds ratio, moderate, or weak odds ratio. Now, for if we suspect a PE with hemodynamic instability, then the latest guidelines have really moved towards just using a transthoracic echo to look for RV dysfunction. So there is RV dysfunction, then if it's feasible, they do a CTPA immediately. If it's not, if CTPA is not immediately available, they still start treatment for high-risk PE before confirming with a CTPA. So that has changed a little bit, that there's no necessity for CTPA if they have RV dysfunction. So they have defined hemodynamic instability if patients have cardiac arrest needing resuscitation, if they are in obstructive shock, systolic blood pressure less than 90, or they need vasopressors to achieve BP of less or equal to 90 despite adequate filling status, or with an organ hypoperfusion. Or they have persistent hypotension, systolic BP less than 90, or drop in systolic BP of equal or more than 40 lasting longer than 15 minutes, which are not caused by new onset arrhythmia, hypovolemia, or sepsis. Now, they've gone to great lengths to explain RV dysfunctions, the presence of any of this: enlarged right ventricle in the parasternal long axis view, dilated RV with basal RV to LV ratio with a typical McConnell sign. In the four-chamber view, flattened intraventricular septum in the parasternal short axis, distended IVC with diminished inspiratory collapsibility, or 60-60 sign, coexistence of an acceleration time of pulmonary ejection of less than 60 milliseconds, and a mid-systolic notch with a mildly elevated peak systolic gradient at the tricuspid valve. Sometimes we can see a mobile thrombus in the right heart cavities that could change the diagnosis for us. The decreased TAPC in the M mode, less than 16 mm, or a decreased peak systolic velocity of the tricuspid annulus. So the next step of, that is in acute PE. PE with hemodynamic instability. But if we suspect PE without hemodynamic instability, then the probability of PE is again determined by scoring. Again, there's a Well score, a Geneva modified score, which I will go to after this. So it depends. If the patient is in a low or intermediate probability or PE is unlikely, then they warrant a D-dimer. If the dimer positive, then only we do a CTPA and then confirm a PE. If there's a high clinical probability and PE is likely, then we do a CTPA straight away without D-dimer. So the pre-test probability using the Well score, again, the simplified version. We use a simplified version. So whether P is unlikely or likely, and then go based on the algorithm to determine and to confirm PE. And there's also the Geneva score, which is similar, using all these parameters to determine if what's the next step. So they recommend the Geneva score because it's validated criteria to diagnose PE, and the diagnosis strategy will be based on clinical probability, either by clinical judgment or validated prediction rule. Now, the other thing is to do the Pulmonary Embolism Severity Index. It's a classification of mortality risk. Classified to high, intermediate, or low mortality, and intermediate, high, or low. So it's based on shock or hypotension and PASI scoring, and then looking at RV dysfunction and laboratory markers, namely troponin T and proBNP. This becomes important for treatment and then long-term treatment as well. So now we look at acute phase treatment of high-risk PE. The recommendation is anticoagulation with unfractionated heparin, weight-adjusted bolus injection, and then it's to be started without delay. Systemic thrombolytic therapy is recommended for high-risk PE, and it's a class 1 indication now. Surgical pulmonary thrombectomy is also recommended if thrombolysis is contraindicated or failed. So they've recommended us to use either alteplase, streptokinase, or urokinase at these adjusted doses for thrombolysis. And I think it's also important to note treatment of RV failure and acute high-risk PE. I think Ruth has touched on this. Optimize the volume, vasopressors and inotropes may be important, but we also have to be careful not to vasoconstrict the patient. And ultimately, if all this fails, they may need MCS. Now, moving on. So again, in high-risk PE, there are some patients who are not, who we cannot thrombolyze, or they don't want surgery, or the surgeons don't want to take the patient out. We may have to do some form of percutaneous catheterectomy therapy. It's a class 2A recommendation, but it's actually gone up in recommendation. And to be very honest, we do a lot of CDT with ECOS catheters in IJN with very, very good outcome. The bleeding risk to me is definitely much lower than systemic thrombolysis. And like we discussed earlier about epinephrine, dobutamine, and ECMO. Now, in intermediate or low risk PE, again, anticoagulation should be initiated without delay in the high intermediate probability while we do the workup. Recommended anticoagulation here is low molecular weight of fundoparinox and not unfractionated heparin. And NOAC is again preferred. If it's warfarin, we aim for INR of 2 to 3. Now, if the intermediate or low risk PE becomes hemodynamically unstable, we can do rescue thrombolysis. Alternative thrombolysis, we may refer for surgical embolectomy or CDT. But routine thrombolysis is not recommended for intermediate or low risk PE. Now, a recommendation of treatment for anticoagulation is at least 3 months for all patients with PE. If the patient is the first PE or venous thromboembolism secondary to a major transient or reversible risk factor, like we saw earlier, we may stop it after 3 months. We can give anticoagulation indefinitely if it's a recurrent VTE, which is not related to a major transient or reversible factor. And again, for antiphospholipid syndrome, warfarin is preferred. Now, for patients who present with first episode of PE without any identifiable risk factors or a persistent risk factor other than antiphospholipid syndrome, or a first episode with minor transient or reversible risk factors, we can consider to extend the oral anticoagulation. And in the intermediate group, for same as DVT, we may consider to reduce the dose of apixaban and rivaroxaban after 6 months. There's also sort of a recommendation that those who refuse or unable to take NOAC, aspirin, or sulodexide may be considered to extend VT prophylaxis, but I personally do not have any experience with this. So now, follow-up strategy. So once the diagnosis of acute PE is made, we anticoagulate, we stabilize the patient, discharge the patient. So they are followed up either at 3 or 6 months. So we assess whether they still have dyspnea or any functional limitation. If they don't, we assess for other risk factors of CTPH and follow up. If they do, we do an echo to look for pulmonary hypertension, If the pressures are low, then we look at other causes of dyspnea. If the pressures are intermediate, we look at other parameters like the proBNP, other risk factors with CTPH and abnormal cardiopulmonary exercise testing results. If they are present, then we do a VQ scan, and obviously we refer to the CTPH experts for further diagnostic workup. So most pulmonary emboli obviously arise from DVTs, which are very common in immobilized patients or in the medical, surgical, and obstetric wards. So many times when I speak to my orthopedic colleagues, I always tell them, when you're doing knee replacement or hip replacement, please prophylaxisly give the patient low dose NOAC maybe for up to 10 days to 2 weeks. And a lot of them actually do that now. So assessing a patient suspected of PE involves a proper assessment of the clinical symptoms and risk factors, and also excluding other diagnoses. CT scan is currently used as the main imaging modality, but in acute severe PE, I think an echo to look for airway dysfunction has become very important. So I thank you. I'm done with my talk, but I do have a sample question which we can put up. Vishnu, what do you think?
Yeah, sure. Would love to see the questions.
Okay, so this is one of the questions from the EECC what do you call study dietetic. So 70-year-old man seen in the clinic. 3 months previously, he had a first episode of acute pulmonary thromboembolism after a hip replacement, for which he was taking apixaban 5 mg twice a day. He had no other identifiable risk factors for pulmonary embolism. His renal and liver functions were normal. So what is the most appropriate recommendation for his anticoagulation therapy? So to continue apixaban, the current dose indefinitely, to reduce the dose of apixaban to 2.5 mg twice daily, replace apixaban with aspirin or Plavix, or stop apixaban. So these are kind of questions that you can expect in the exams, if those are going for the exams. I don't think they can shout out answers.
Yeah, it's okay. We can discuss about it. But you can see that the question is quite specific. It's really specific in the guidelines, not just a general concept.
Yeah.
Okay. So do you probably want to answer that and discuss a bit?
Yeah.
Jaya?
All right. So this is so the answer is obviously E. We can stop the apixaban. It's a classical PE probe by operation. So there is a reversible risk factor. So discontinuation is recommended in this patient. Yeah. So, but if we have no identified risk factor in this patient, then probably we can do a look at risk assessment. There's one part that I did not actually cover, is risk assessment for continuous. So again, they divide into low, intermediate, or high risk based on their underlying medical conditions and whatnot. And based on that, we can decide whether this patient should be discontinued, should be continued at lower dose, or indefinitely continued. Thank you.
Oh, thanks a lot, Jaya. That was
Happy
an
to
excellent
take questions.
presentation. Yes.
My apologies for speaking really fast, because I was in the impression that I needed to finish all this in 30 minutes. There's so much to cover. So I'm happy to take questions and or comments.
You're really on time. Thank you for taking a huge task of covering all of the peripheral arteries emergencies. So we have one question in Q&A, and it's about pulmonary embolism. I think you have shown the first question in your presentation. So the first question is, what will the panel suggest when performing systemic thrombolysis for massive pulmonary embolism? And when will be the time to restart the heparin after giving systemic thrombolysis? And what doses of RTPA should be given? Either 100 milligram over 2 hours, or a dose up to 50 milligrams. And the second question is, what about a submassive pulmonary embolism with RV dysfunction? Will you just wait or do straight to thrombolysis or thrombectomy? Do you have
these are two good questions. Number one, I usually look at the half-life of what drug I'm giving. The problem here is in IJN, I rarely do thrombolysis. Most of the time I use catheter directed if the surgeons are not going to go in. So based on the half-life of the drug you're giving, I think once you've given a acute dose, during the infusion, obviously you stop heparin, probably 1 or 2 hours later, I think it's fairly safe to start back unfractionated heparin. Dose of RTPA, I'm sorry, I don't remember offhand. Maybe I can just quickly look at my slides, and it's there on the slides. Give me a second. So the recommendation from the guidelines is 100 milligram over 2 hours, or 0.6 milligram per kg over 15 minutes, but to a maximum dose of 50, right? So in submassive PE, I actually sit down and have a discussion with the patient. I tell them, look, we can treat you conservatively, or we can do catheter directed, and ensure that we clear the clots. But I may not keep the catheter very long. A lot of times with the ECOS catheter, I just keep it for 6 to 12 hours at most. We use a very easy dose of alteplase, which is 1 milligram per hour. If it's bilateral, 1 here, 1 there. When I put in the catheter, I give a bolus of 1 to 2 milligrams of alteplase, and I remove it within 6 to 12 hours. So it's quite amazing, really. I mean, it's of course it's class 2B, but in a personal experience, I've had a really bad patient come. Initially, was a submassive PE referred from another district. By the time patient arrived, she couldn't lie flat, so I called my NS. I said, look, we have to go in, and I think she needs to be intubated beforehand. There's no way she's going to lie flat. So by the time I mean, the procedure took 15 minutes for me because it's just a venous puncture, put in 2 catheters, and you're out. Surgeon took about, I mean, my NS took about half an hour, maybe 45 minutes to get her prepared. And by the end of it, she was on nitric oxide, maximum support. She was on milrinone, and her BP was barely holding on. Her PO2 on nitric oxide maximum support was about 70 or 80. And within 4 hours of initiation of catheter-directed thrombolysis, her PO2 was 400. And, you know, we managed to wean her down within 24 to 48 hours, and she went back home very well, and she's doing very well now. Unfortunately, I don't know, sometimes we have a saying in Malay, in sudah jatuh di tipe tangga, that means you fall down and the ladder falls on you. So she ended up having cervical cancer. Oh God. And she was absolutely asymptomatic for 6 months. Her HB was stable. She comes for follow-up at 6 months and the HB drops to like 6. And then we investigate and she has cervical cancer. So unfortunate.
Yes, yeah. But that's a good story. So how aggressive with PE would you love to do intervention? Probably Satoshi, you can have some insights.
Unfortunately, I'm not so familiar with pulmonary embolism because my hospital have pulmonary artery department, so other doctors treat the patient. So I'm sorry, I'm difficult to provide precise answer for that.
Okay, so different departments. Yeah, but that's the real condition.
Yeah, but I a lot of times in the real world, I mean, guidelines are guidelines. Of course, we have to follow guidelines, but sometimes in the real world, when you don't, I mean, I have a surgeon, but my surgeon's on leave this week. He's away for a conference. So if my vascular surgeon, so if my cardiothoracic surgeon says, hey, look, especially for a bad DVT, if he doesn't want to do anything, then we sometimes our hands are tied. If we don't do anything, the patient just gets worse and we have to go and do something. So I've had a very bad acute limb ischemia, actually, where I also did catheter-directed thrombolysis. We managed to reperfuse the patient. His feet was warm, but unfortunately, the foot drop never recovered. The foot drop never recovered, yeah. But he presented to us like almost a month, 3 weeks to a month after the initial event. He was just on medical therapy.
Dr. Jaya, may I ask a question about acute limb ischemia? So,
Sure.
Yeah, so in LI, there is a golden time to salvage the lower limb, and but once the time pass, the time is too late, we need to go amputation. So how can we distinguish patients who have salvaged the limb or not? What is the
I think the easiest is we go back to the classification earlier. When the early signs, that means the pain, when it's pale, when there's no pulse, or they're starting to get cold, this is the best time to do something urgently. If they have already reached a state where they're feeling numb, or they cannot move the legs, and we know we are reaching, we may have a few hours depending on when they present to us at that point. But a lot of times when if there's foot drop and they can't walk, the likelihood of salvaging the limb becomes very, very, very small. But a lot of times I give the patient the chance, meaning that I go and salvage, reperfuse, and see if there's any improvement. Maybe we can prevent amputation, but they do walk with a limp, and if there's persistent pain, then we have to manage the pain, so on.
Thank you very much.
Jay, if you don't mind, I want to touch the issue of reperfusion injury, which is very commonly assumed a lot in limb ischemia, in lower limb ischemia. How often do you find reperfusion injury, and how do you prevent it?
I think I have encountered a few actually. The key is, I think, really monitoring. I mean, you have to monitor CK levels. You know that when you come with patient ALI, CK levels are going to be sky high. You have to adequately hydrate the patient. Monitor lactate. If you need to give antibiotics, if the legs are extremely swollen, you may want to call in a surgeon early to do a fasciotomy to make sure there's no compartment. This is basically supportive management. There's really nothing specific that you can do. You hit hard and early with hopes of coming through them. I've seen patients whose CK levels are so high, kidney gets damaged when to dialyze the patient, and sometimes it's like a cycle which you go downhill and you never come out from.
Is there any condition that when you don't want to do intervention because you're afraid of the reperfusion injury? For example, probably the area is there's lots of area that covered by it's very proximal stenosis. The area is a lot, and then probably the leg is very swollen. Or
I think if the leg is extremely swollen, I definitely be very concerned, because we can't even do catheter-directed thrombolysis in that case, because there might not be any perfusion because of the compression. And a lot of these times we have to sit down with our surgeons and then see what we can do. And sometimes my surgeon will tell me, Jaya, don't touch the leg, because I think this is a downhill sort of thing. So again, it comes back to a multi-team. Sometimes it's not one person making a decision. It all depends on what we find. But to be honest, the last ALI I treated was probably a year and a half, 2 years ago. It's been a while now. Not seen one, touch wood. It's good for the patients.
Okay, that's great. So I think we're running out of time and we have to close the session. It's been a really great session about acute cardiovascular situation, and we have both heard from Ruth about the managing acute condition from the heart, and from Jaya about the managing acute condition from the peripheral vascular condition. And I think it has been a fruitful session, and personally I learned a lot, really. And also thanks for all the participants who has been participating, especially participating in Q&A. We heard lots of good questions, and really appreciate you all. And fair to say that it's been a really successful first episode of the APSC Core Cardiology Review. Thank you.
Thank you, everyone. Have a good
So
day.
I will also want to show the last slide. So this is just want to invite everyone to our upcoming episode. So it will be on 18th October 2023. And it will be episode 2 of this core cardiology review series. It will be about updates in electrophysiology. So stay tuned, and hopefully you can also join our second episode. So thank you all for joining, listening, and thank you for all both our speakers and also Dr. Satoshi to co-chair this session. We'll see you on the next episode. Okay, take care. Bye.
Thank you.
Bye, everyone.
Thank you.
Thank you.
Bye, guys.
Bye.